Hi, good afternoon. It's John Snyder, Thursday, September 3rd. I want to welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. Today we're delighted to have with us Dr. Pam Weinfeld and Dr. Dion Wolpowitz from our dermatology department. And they're going to talk about comprehensive, compassionate, state-of-the-art care, medical, surgical, and cosmetic dermatology. Next slide, please. As you know, all of these talks have CME credit. We do post them also up onto YouTube, and you can find them. Next slide. Here's the code. I'll put that in the box for your CME. You can find them by going to YouTube and just searching for Newton-Wellesley Medical Group Lunch and Learn. And I want to tease the next 2 weeks. Next week, we're excited to have Dr. Lancaster and Dr. Mahapatra talk about peripheral artery disease. And the following week, we'll be talking about substance use disorders, which I'm really excited about. So I'll turn it over to Dr. Wolpowitz and Dr. Weinfeld. Thank you guys for coming. And any questions you have during the talk, please throw them into the chat room, and hopefully it'll go well. Thanks.
Thank you so much, Dr. Snyder. Really appreciate it. And thanks to everyone for being here. I just want to start by introducing our group a little bit. We're called Dermatology and Skincare Associates, and the reason we picked that name was to focus on the fact that we are comprehensive. We treat the skin in many different ways. So dermatology as a medical practice and also taking care of people's skin in general. So we focus on comprehensive and compassionate state-of-the-art care. We cover medical, surgical, and cosmetic dermatology, and we see patients of all ages. And on the next slide, you can see our team of
people getting credit signing on.
physicians. Oh, maybe someone, I think someone needs to mute. So we can see on this slide our team of physicians, and I'll just introduce everyone very briefly. So Dr. Goodkin and I started this practice about 12 years ago. We met at Harvard Medical School as classmates. Dr. Goodkin focuses on general dermatology, sees patients of all ages, and has an interest in itch. My focus is on medical, surgical, and cosmetic dermatology. I love seeing all kinds of patients, everything ranging from acne, warts, skin cancer. I focus a little bit on medical uses of Botox as well as cosmetic. Dr. Lynn Baden joined us last year after practicing dermatology for 30 years. We're very excited to have her join our practice. She's a second-generation dermatologist. She works 3 days in our office in Wellesley and 1 day at Mass General, and loves seeing acute rashes and diagnosing and treating skin cancer. Dr. Larea completed fellowship in pulmonary and critical care before doing a dermatology residency, and has the distinction of having been chief resident twice. And she focuses on general dermatology and skin cancer and individual management of general dermatology patients. Dr. Haran is an allergist at the Brigham and also works at our practice and adds another dimension to our care. Dr. Steve Smith is our Mohs surgeon. He's the longest tenured Mohs surgeon in the Newton-Wellesley network, and is a great addition to our practice to help us broaden our scope of what we can offer. And Dr. Wolpowitz, who's giving our presentation today, is also a dermatopathologist. So he focuses on the clinical correlation of diseases, and it's really amazing to be able to bring him in and see the patient, and he can look under the microscope and correlate those things, so we can really offer advanced diagnosis to the patients. So it's really fun to work in such a great, inspiring group of physicians. I really enjoy coming to work every day. Next slide. Our office is in Wellesley. It's just down the street from the hospital. So it's about 2 miles down Route 16, about 1 block before Playhouse Square. There's a picture of our building right there. So it's easy drive from the hospital. Next slide. And to keep our patients safe during COVID, we've instituted some new precautions. So our patients actually are waiting in the parking lot before coming up for their visit. So we call them to come right up. All our staff are wearing masks, physicians also wearing face shields. We don't have any recirculating air, and all the rooms have HEPA and UVC air cleaners. So we're able to offer, very safe care for all the patients who are coming into the office. Next slide. And now I'm going to turn it back to Dr. Wolpowitz, who's going to give us the heart of the presentation today.
Okay, thanks, Pam, and thanks, John. My talk today, is it switching to me?
Yes, you're on.
Okay, great. My talk today is going to be advances in the treatment of common skin conditions, and primarily focusing on psoriasis and atopic dermatitis. I have no financial conflicts of interest, and there'll be no off-label drug discussion. The overview of the talk today is that I'm going to introduce the skin diseases, summarize management strategies, and the aims are to identify practice gaps and discuss treatment advances designed to fill these gaps. So I'll start with psoriasis. Psoriasis is a systemic autoimmune inflammatory disorder. When I mean systemic, it means that it has both cutaneous and extracutaneous manifestations. So cutaneous manifestations are these characteristic skin lesions that are well-defined erythematous and have a scale that's white and described as silvery. When the skin lesions are less than 5 to 10% of the body surface area, it's considered mild. And when it's greater than 5 to 10%, it's considered moderate to severe. Extracutaneous manifestations are primarily a seronegative inflammatory arthritis, which is seen in about 20 to 30% of all patients. However, psoriasis has also been linked to cardiovascular disease, and it's been definitively shown in the literature that the psoriasis population has a high prevalence of traditional CV risk factors such as smoking and excessive alcohol use, as well as features of metabolic syndrome such as hypertension, dyslipidemia, abdominal obesity, and insulin resistance. It's also been shown in the literature that this population has increased CV morbidity, including increased risk of MI and stroke and increased cardiovascular mortality, particularly patients who have severe disease. Currently, what we think is of exciting active areas of research is whether or not psoriasis itself will be an independent cardiovascular risk factor and whether or not psoriasis-specific treatments will reduce CV morbidity and mortality. Regardless, this leads us to our first practice gap, that this population has a high prevalence of underdiagnosis and undertreatment of the cardiovascular risk factors. So for example, in one study looking at about 2,900 patients, they had moderate to severe psoriasis, so more than 5 to 10% of their body surface area. What this column here shows is that at the start of the study, the percent of patients with either diabetes, hypertension, and hyperlipidemia who knew they had it but were entirely untreated. What this column shows is the percent of patients in the study who met standard of care treatment goals when they enrolled. And so you can see, for example, for diabetes, only 36.7% of the patients met these treatment goals. And to put it in context, in the general population of type 2 diabetics in the United States, between 50 to 57% of them are at their ideal treatment goals. So this gives us the opportunity to try to close this practice gap by collaborating with primary care providers to identify these at-risk patients and refer for appropriate evaluation and management of these comorbidities and risk factors. And again, just to summarize who in the psoriasis population are at risk, the highest ones at risk would be those with psoriatic arthritis or those with severe disease, such as body surface area more than 5 to 10%. So I'd like to transition now into the management of cutaneous psoriasis. And when the disease is mild, localized treatments are sufficient. And these are usually mid to high potency steroids, topical vitamin D3 preparations or a combination of both of them, or intralesional steroid injections. When psoriasis is over a larger body surface area, these topical treatments are either insufficient or have contraindications, and this requires systemic treatments. The longest standing systemic treatment are immunosuppressives like methotrexate and cyclosporin. For me to introduce or discuss how we evaluate their efficacy, I briefly need to discuss the Psoriasis Area and Severity Index, or PASI score. The PASI score is best explained with an example. So when this patient entered a clinical study, they were deemed to have a PASI score of 14.2. By the end of the study, they had improved and the PASI score dropped to 4.2. So this would be described as a decrease in the PASI score of 66% or a PASI 66. What I'd like to stop and just point out is that when you eyeball it, the patient improved by more than 90%. So in a clinical study, the standard of care is a PASI 75 or a 75% reduction in PASI score from baseline. So this patient wouldn't have met the primary endpoint, but I think most dermatologists and patients would be very satisfied with such a good clinical improvement. So when we go back to methotrexate and cyclosporin, they're both equivalent. So in one study, methotrexate 36% of patients met the PASI 75, so had a 75% reduction in PASI score from baseline, and a 41% in the other, and this was statistically significant. So they're pretty effective, but the problem is they're non-specific. So they not only inhibit psoriasis, but they also inhibit immune system pathways for cancer surveillance and infection prevention. They also target other organ systems such as the liver, kidney, and cardiovascular disease. And the problem with this is that then they have significant adverse side effect profiles, particularly in the psoriasis population that already has a higher prevalence of cardiovascular disease risk factors. So the practice gap here is a need for safer treatments for systemic disease. And so at Dermatology and Skincare Associates, we're lucky enough to have one such option, which is narrowband UVB phototherapy. So phototherapy is suppression of psoriatic skin lesions in response to exposure to ultraviolet light. When patients come to the office, we can have the opportunity to treat them in a booth where these light bulbs will emit not all of UVB, but just one limited wavelength, 310 to 311. Selected because this is highly effective at suppressing psoriasis lesions, but is has a relatively low risk of causing sunburn, so it maximizes the safety profile. We also have the opportunity to treat people with an eczema laser, which is a handheld device, which releases monochromatic laser light at around 308 nanometers. So what's very nice about this is that we can treat either the whole body in the booth, or we can treat selective areas, including the scalp, which oftentimes don't respond well in booth treatment. How effective is it? It's extremely effective. So in one study, over 18 sessions, the average reduction in PASI score of the study population was 84%. And in another study, after 12 weeks, 92% of the patients reached a PASI score of 75. And remember, the methotrexate was around high 30s, low 40s. People usually clear coming 2 to 3 times a week in about 10 to 15 weeks. And using a maintenance protocol that we have in our office, about a little more than half of them remain disease-free for at least 1 year after their last treatment. It's also not systemically immunosuppressive, so it's very safe, including in pregnancy. So while we are very glad at our office to be able to have narrowband UVB phototherapy as one other option for these patients, we can also offer them the newest class of treatments, which are systemic biologics. And these are immune modulators that primarily target specific cytokines. And I'm going to very briefly discuss the pathogenesis of psoriasis to put these in context. So psoriasis will start with some trigger in the skin like trauma or bacterial infection or drug, which elicits a signaling pathway from the skin into the dermis. And in the dermis, this causes an activation of a subset of dendritic cells, leading to the production of TNF-alpha, which in turn leads to the production of IL-23, which primes a Th17 immune response. The Th17 immune response leads to the production, amongst other things, of IL-17, and IL-17 is primarily what's responsible for causing dermal inflammation and the keratinocyte proliferation that takes the skin and turns it into these red scaly plaques. So in this context, there are 3 groups of biologics. The first inhibit the cytokine TNF-alpha. The second inhibit the cytokine IL-23. And the third are the IL-17 inhibitors, 2 that target the cytokine and 1 that targets the receptor. So the next question is, how effective are these? And the answer is extremely effective. So the TNF-alpha inhibitors that are injectable have PASI scores in the 50s, and the 1 IV form is in the 80%. The IL-17 inhibitors have PASI scores in the 75 to 85% range, and the IL-23s were so effective that some studies looked at PASI 90 instead of PASI 75, and were still up in the mid-80s. So this leads us to a situation where we almost have an embarrassment of riches. We have this broad number of very effective treatments that are also highly safe. To date, in post-marketing studies, none of them have been shown to have an increased risk of cancer or infection. I will point out, though, that they're currently still required to have patients get yearly TB tests, and when patients are on these medicines, they should not receive live vaccinations. So how could we pick one versus the other? This in and of itself could be a whole talk. I'll briefly say that these clear people in only 4 injections a year, these in about 12 injections a year, and these in about 26. There are some clinical nuances I'll briefly go over that help us also make decisions. TNF-alpha inhibitors are contraindicated in heart failure. IL-23 inhibitors are currently not approved for psoriatic arthritis, but there's a study that just showed one is effective, so that's probably going to change with time. And the IL-17 inhibitors, while effective in psoriatic arthritis, are contraindicated in inflammatory bowel disease. So that now, just to summarize again, we now have these 3 classes of treatments, but at our office, we use still more that are available. And I'm only going to very briefly talk about 2 others. One is apremilast, which is a phosphodiesterase 4 inhibitor. This is a pill similar to methotrexate and cyclosporin. It also has similar, PASI scores around 40%. However, unlike these medicines, it has a much safer side effect profile. And so it definitely has a place in our office for treating these kinds of psoriasis patients. And then there's acitretin, which is a vitamin A derivative. And this one is usually used for erythrodermic or pustular psoriasis, 2 variants I didn't talk about. And I personally primarily use it in combination with Narrowband UVB because it thins out the plaques and allows people to clear with a lower dose and in quicker treatments. So now I'm going to switch for the second half of the talk to atopic dermatitis, which is like psoriasis, an inflammatory disorder, but it is characterized by intense itch or pruritus, and it's been called the itch that rashes. Its onset is in childhood, although about 35% of cases persist to adulthood, either as a relapsing or chronically relapsing disease. And in adults, it primarily targets flexural areas like behind the knees or the antecubital fossa and the neck. However, a good 20% of adults get moderate to severe disease where it extends over their body. And at higher power, these lesions have a characteristic feature called lichenification, which is accentuation of skin markings because of the chronic scratching. Sorry, so the management of atopic dermatitis is essentially requires behavioral modifications by patients, which are extremely important, but beyond the scope of this talk. It would include things like keeping your skin very well hydrated, avoiding triggers like chemicals or fragrances, and preventing bacterial infections. What I would like to focus on is how we treat mild versus moderate to severe disease. So mild, like psoriasis, can be treated with localized treatments such as topical steroids or topical calcineurin inhibitors, such as topical tacrolimus. However, these topical treatments have limitations. For the topical steroids, prolonged use can cause steroid atrophy and stretch marks. And for both of them, when used over large body surface areas, we get concerned about systemic absorption. There are animal studies that show that topical calcineurin inhibitors can cause increased risk of lymphoma when used over prolonged periods of time over large body surface areas. So we would like to be able to have a topical anti-inflammatory that would be safe for this exact situation of large body area needing to give it for long periods of time. And it turns out that recently a medicine has been improved called Eucrisa, or 2% Crisaborole ointment, and it was approved for mild to moderate AD in adults and children over 3 months of age. It's again similar to that psoriasis medicine I told you about, apremilast. It's a small molecule topical phosphodiesterase 4 inhibitor. There have been studies that when used twice a day for 28 days, about 50% of the patients cleared with almost no side effects at all, basically just stinging and burning. However, in our practice, it turns out that we only use this as a second-line treatment. Its efficacy has not been impressive. And when you go back and look at the study, this was hinted at, although 50% of the people cleared, a high percentage of the vehicles also treated patients also cleared. So that then leads us again to this practice gap of when we have moderate to severe patients, which are about 20% of the population of adult AD patients, what can we give them if we don't have topicals? So that leads us again to the systemic medications I talked about, such as methotrexate or cyclosporin, which are effective, as is narrowband UVB, which is highly effective and dosed exactly like I told you for psoriasis. And with the last part of the talk, I want to focus, though, on this burgeoning field of biologics, where atopic dermatitis seems poised to become, like psoriasis, an area where there are many different specific immunomodulators targeting AD pathway. So very briefly, the pathogenesis of atopic dermatitis starts with these patients having genetic mutations in their skin that allows environmental allergens to penetrate and establish a cytokine signaling cascade, which is complicated but ends in a Th2 shift, predominantly caused by the cytokines IL-4 and IL-13. The Th2 shift also produces itch-making molecules like IL-31, and that causes scratching. And the problem with that is that further disrupts the barrier, allowing more allergens in, driving more Th2, driving more itch, driving more scratching, and you get this itch-scratch cycle and the lichenification I talked about. So enter the first monoclonal biologic to break this itch-scratch cycle, which is called Dupixent, and it targets a joint receptor shared by both cytokines IL-4 and IL-13. It is approved by the FDA for moderate to severe disease with injections every 2 weeks. I'm not going to go into the study, but it was shown to be highly effective, and again, with minimal side effects. Injection site reaction, nasopharyngitis, and conjunctivitis is maybe its most severe problem, which in most cases is minor and treated with ophthalmic solutions. But Dupixent is really just the tip of the iceberg. There are probably 5 or 7 medications right now in phase 2 or phase 3 studies, and I'm just going to briefly point out 3 of them. 2 of them are IL-13 inhibitors, and 1 is an IL-31 inhibitor, which has actually made it to phase 3 studies. So it seems that in the future, maybe we'll be able to come back and talk about AD drugs that are also highly effective for suppressing this chronic itch and rash. So just to summarize then, at Dermatology and Skincare Associates, we like to treat psoriasis and atopic dermatitis by coming up with an individualized therapy for each patient. We look at the extent of the disease and its effects on the patient's quality of life. We're just as happy to treat mild cases as we think we are well equipped to handle these more moderate to severe cases. We weigh the benefits and potential side effects of the specific treatments, and we come up with a plan that is often multimodal, requiring several of these medications, and if needed, multidisciplinary. For example, we want to partner with you to manage these disease-associated comorbidities, such as the cardiovascular risk factors in the psoriasis population. Finally, we understand that we're in this for the long term because these diseases are chronic. There's no cure. Any given patient will cycle between different therapies over time, and we also need to critically evaluate and adopt new and efficacious treatments for limited and severe disease. Ultimately, though, when we step back and look at how we take care of patients at Dermatology and Skincare Associates, it's this approach we think applies to all of our patients. And I think I'm going to let Dr. Weinfeld then finish up the talk describing this in a bit more detail.
Thanks, Dion. That was really great. We really appreciate all the effort you put into making the talk. So just to talk a little bit about our office, we were told we could just introduce ourselves a little bit more. I want to talk about the different services we offer so that you know what's available for your patients. So in terms of our medical dermatology, we will see people of all ages, adults, teens, and children. We'll see rashes, skin cancer screening, treatment of acute and chronic skin disease. As mentioned before, Dr. Wolpitz is also a dermatopathologist, so we have the specialty of being able to correlate what's under the microscope with the patient in front of us, which helps for diagnosis. And Dr. Wolpitz also talked about our phototherapy unit, which is used not only for psoriasis and eczema, but also to treat vitiligo, cutaneous T-cell lymphoma, and alopecia areata, and some other hair disorders. Next slide. We also have our Dr. Smith, our Mohs surgeon, and a lot of our physicians also do general surgical dermatology, so we can excise benign and malignant skin lesions, take off cysts and lipomas, and Dr. Smith offers treatment of basal cell, squamous cell, and even staged excision for melanoma in situ. For patients with severe disease, if they need to have lymph nodes done, we do have relationships with Mass General and the Brigham, and we can get people into the dermatology clinics there as well if there are things that are beyond the scope of what we offer in our office. But we are very comprehensive and can treat most things right here in Wellesley. Next slide. We also do some bread and butter cosmetic dermatology. So we focus on a cosmetic look, on a natural look. We're not a Hollywood practice at all, but we can offer patients sort of basic, and there are some photos before and after here of, for example, on the far left is a Botox patient. We can get rid of some forehead wrinkles. We did laser. The next one is an angioma, so an unsightly growth on someone's face. We can soften some wrinkles with fillers and get rid of brown spots. You can see that on the far right with a laser treatment. So these are just basic things that we can do for your patients in our office. And we have an esthetician who does also some peels and facials and things. So just really comprehensive, treating the entire skin. Next slide. And then we pride ourselves on same-day urgent access. So if your patient needs to be seen right away, you can either put in a referral in Epic. We'll call the patient to contact them if they need to be seen ASAP right away. Just call our office, or you can message our urgent pool. So we'll leave this up here just as the different ways to contact us. But we really do want to help you care for the patients. We feel strongly about being a team player in the network, and we'll help out as needed. So you can feel free to reach out to us either individually or to our whole group. And thanks so much for this opportunity to present to you today.
Thanks, Pam and Dion. That's a really great review. Appreciate it. There was a question about doing home treatments, I think was answered in the chat box. One of the questions I had, and we struggle with as primary care docs, is trying to get some of these creams and procedures approved, especially when it comes to second level, when you pass the kind of topical corticosteroids. Any tricks or tips when it comes to that for you guys?
So we struggle with that too sometimes, and we have to write letters and really, go to bat for the patients to get things approved. Sometimes within a steroid class, a certain insurance company will cover some agents and not others. Sometimes you can call the pharmacy and go through the patient's insurance, and they'll help you figure out which ones are covered and which aren't. A lot of times you have to do step therapy, so we have to give a patient a prescription, knowing it might not help them, but just to get them to the next level. So we'll do all those things, working through things with the patients, but we have the same frustrations you have with getting things covered.
And the UV treatments, you said 18 to 22 or so typically, is that just typical copay for the patients? It's usually the whole thing is covered on those kinds of visits?
So it depends on the insurance, whether the patients have co-pays for the visits or not. A lot of times they do, but it is, we will again write letters and get things covered. It's interesting because it used to be very hard to get phototherapy covered, but now the biologic therapies are so expensive that the insurance companies, I feel like, are almost relieved to have the patients have light therapy instead, because that's cheaper for them. So it's a little easier right now to get that covered, but we'll work with them, and we call the insurance companies and do the appeals and all that for them to get things covered that we need.
Right. I think.
Can I quick comment about that? The other thing I didn't get to say for shortness of time is that when they finally cleared, oftentimes they can come one time a week for many months and stay clear. No creams, no rash, nothing. And many patients don't have a problem with that because it's just so convenient.
Sure. And Dr. Panesian asked if you can go straight to the biologics, or typically you always have to start with the methotrexate, cyclosporin in general from an insurance point of view. Is that what you were just alluding to, Pam?
Yeah, I mean, we don't have to try methotrexate or cyclosporin first for most insurances, but sometimes they'll require something more significant, so we can do light treatments first, and if that's not working, do biologics. Or sometimes there's something in the patient's chart that the insurance company will accept. For example, if they ever had an elevated liver enzyme, we can just say, hey, they don't qualify for methotrexate, we should do biologics. And so I think we just comb through the patient's charts really carefully and talk with them and work with the insurance to get them what they need.
Okay, great. Thank you so much. It's coming up on 1 o'clock, so I'm going to give everyone back the rest of the day. Appreciate everyone signing on this Thursday. Hope everyone has a really nice, enjoyable, long Labor Day. Hopefully the weather will clear up for us. And we'll see you all next Thursday. Thanks again to Dion and Pam. I put the code in the box. It's RED FAY for CME. Everyone have a nice day. Thanks.
Thank you. Bye-bye.
Thank you.